Welcome to the resident curriculum on hypothyroidism. What you really need to know about hypothyroidism, especially if you're in internal medicine. I'm Ty Carroll. I'm an endocrinologist here at MCW. I'm the fellowship program director. And for about the next 20 minutes, I'm going to talk about hypothyroidism and everything that you need to know. Here are our topics for discussion. We're going to talk about diagnosis, treatment, monitoring of hypothyroidism, and then a little bit about T3, T4 therapy. So some background on hypothyroidism, just so we're all in agreement about what these terms mean. Hypothyroidism is the underproduction of thyroid hormone for any reason. So primary hypothyroidism is thyroidal failure, and that's 95% of all hypothyroidism. It's by far and away the most common reason that people have hypothyroidism. If we're talking about overt hypothyroidism, which we often just refer to as hypothyroidism, these individuals have elevated TSHs and low T4 levels. They may or may not have low T3 levels, and it's about 5% of the US population, so a significant number of individuals. Subclinical hypothyroidism are individuals who have an elevated TSH with normal T4 and T3 levels. About 80 to 90% of these people have TSHs that are less than 10, and that's roughly 10% of the population, so 33 million people or so in the US. So when it comes to presentation of hypothyroidism, I think we really all appreciate the signs and symptoms: fatigue, weight gain, cold intolerance, edema, constipation. But these symptoms are really very non-specific. So we don't use signs and symptoms to make the diagnosis of hypothyroidism. Interestingly, if we look at the relaxation phase of the deep tendon reflex, if it's delayed, so there's a slow relaxation phase, that actually has a sensitivity and specificity a little bit above 90%, but the other signs and symptoms of hypothyroidism do not have significant sensitivity or specificity to use those in diagnosis. So speaking of biochemical tests, primary hypothyroidism, like we said, 95% of hypothyroidism, these individuals have a high TSH. In overt disease, like we said, those people have low T4s, and subclinical disease have a normal T4. So if you get a TSH and a T4, you're going to identify all patients who have hypothyroidism. Primary hypothyroidism, all those patients will have an elevated TSH by definition. And if we're looking for secondary hypothyroidism or central hypothyroidism, so individuals who've had pituitary damage, etc., those individuals will have a low T4. They may have an inappropriately normal TSH or a low TSH. But again, if you get a TSH and a T4, you've identified all individuals who have hypothyroidism. When it comes to the etiology of hypothyroidism, for individuals that live in iodine-sufficient areas of the world, so the US is an iodine-sufficient area, the cause of hypothyroidism is chronic autoimmune disease. So you can call that chronic lymphocytic thyroiditis, you can call it Hashimoto's disease, lots of different names, they all mean the same thing. I tend not to use Hashimoto's disease because it often means different things to different people. It's often used by patients and some practitioners to mean people who have positive TPO antibodies but still have normal thyroid function. So I don't think it's very helpful. And patients with autoimmune hypothyroidism have TPO antibodies present in about 90% of cases. So it's very, very common. So I don't find that TPO antibodies are very helpful. If patients have biochemical hypothyroidism, we're going to treat them whether they have TPO antibodies or not. In general, we assume that if a patient has primary hypothyroidism, it's autoimmune disease, unless there's some other clear reason, like they've had their thyroid removed or had radiation therapy. And it doesn't really change the treatment anyways. So you go ahead and treat patients, and I don't routinely recommend obtaining TPO antibodies. Now moving on to hypothyroidism therapy. So we've made the diagnosis and we want to treat the patient. So the therapy of hypothyroidism is levothyroxine replacement. That is the standard, that's the primary therapy, that should always be what we start treating patients with. And there's really three main goals when we use levothyroxine, and that's to provide resolution of the patient's symptoms, including biological and physiologic markers. We want to normalize the TSH, And we also want to avoid overtreatment, especially in older patients. So how do we actually start levothyroxine or LT4 therapy? Well, this is a snippet from the American Thyroid Association guidelines for the treatment of hypothyroidism. And they really say that there's two approaches to starting levothyroxine therapy. You can either use full replacement therapy or partial replacement therapy with adjustment upward if we're using that partial replacement therapy. And they say that it really kind of depends on the individual, and that we need to reassess after we start treatment. So a little bit more detail on the full replacement versus partial replacement schemes. So if we're going to do full replacement, the patients that we generally select for this are younger, healthier patients that have more acute onset of their hypothyroidism. We really do this in almost all patients who had a thyroidectomy and had normal thyroid function previously. We want these patients not to have any extensive vascular or cardiovascular disease because going from a hypothyroid state to a full euthyroid state very quickly can sometimes increase cardiovascular problems as we increase oxygen demands in the myocardium. So with the full replacement dose, we give about 1.3 to 1.8 micrograms per kilogram of actual body weight, and we'll show this in the next slide. We give that full dose, and then we monitor levels and adjust accordingly. So for the older patients or patients with significant cardiovascular disease or more chronic disease, we really start lower and titrate up. How low do we start really depends on the individual. Patients who are quite old, so say someone in their 80s who has a significant cardiovascular disease and has significant hypothyroidism, I might start with 25 to 50 micrograms and go slowly to titrate up that dose. Someone who's sort of in between that and a young healthy individual, you might start with 75 micrograms depending on their body weight, maybe even up to 100 micrograms, and then test and increase the dose as needed. So what this slide is showing if we're using a full replacement dose, using BMI to decide whether we're going to use that between 1.3 or 1.8 micrograms per kilogram. So individuals with lower BMIs, so less than 25, about 1.8 micrograms per kilogram dose of levothyroxine is appropriate. Individuals who have BMIs greater than about 35 or 40, we really should use about 1.3 micrograms per kilogram as the full replacement dose. So once you've started levothyroxine therapy, you want to monitor how well you're doing. About 4 to 6 weeks after a dose is started, whether that's a new dose, so you've initiated therapy, or you've titrated a dose, you should obtain a TSH. Our goal is for the TSH to be in the normal range. I often shoot for a mid to lower normal TSH in most healthy young patients. That being said, there's really not good evidence that TSHs in the lower normal part of the range have any less symptoms than people who have TSHs in the mid to upper part of the reference range. So as a population goes, as long as the TSH is normal, you've done your job. Now, some individuals certainly will report that they feel better with the TSH in the lower part or the mid part of the normal range, and it's not unreasonable for the vast majority of patients to then try to achieve that target with your TSH. So when we talk about levothyroxine, we're usually talking about generic tablets of levothyroxine, or certainly the name brands, some name brands such as Synthroid or Levoxyl. They've been around for a very long time. There are some newer preparations of levothyroxine. They're gel tablets or liquid capsules. There is very limited evidence that would show that these preparations have any benefit over the standard levothyroxine tablet. The underlying pharmacokinetics of these newer preparations is a bit unclear. There are some patients who have absorption problems or intolerances to a standard levothyroxine tab, and we will sometimes try these preparations to see if they work better, but the evidence supporting this is somewhat limited. So in terms of hypothyroidism therapy and TSH, we really focus on that. But the question is, does normalizing the TSH really make a difference? So does having a low TSH or high TSH when you're treating hypothyroidism really lead to complications? The answer to that question is yes, it does. There's a study of almost 3,000 patients in this Danish case control study that followed patients for over 7 years. And if they looked at patients who had a TSH that was above the normal range, for every 6 months that TSH was above the normal range, they had a 5% increased mortality rate compared to individuals who had treated hypothyroidism with a normal TSH. So pretty significant. And if they looked at patients who were overtreated, so they had a TSH that was below or suppressed the reference range, those patients had an 18% increased risk of mortality compared to patients who had treated treated hypothyroidism with a normal TSH. So it really does make a difference to try to get that TSH into the normal range. So a little bit more about monitoring. So we often hear about symptoms and how we should use those to monitor levothyroxine therapy. The bottom line here is that symptoms lack sensitivity and specificity, and they should not be used solely for judging the adequacy of replacement. Obviously, symptoms should be followed and considered in the context of TSH, comorbidities, and other potential causes, but we don't use symptoms in and of themselves. If people aren't feeling it as well and their TSH is in the upper part of the normal range in an otherwise young, healthy individual, then increasing the levothyroxine to get that TSH into the mid or lower part of the normal range seems appropriate, but we wouldn't use those symptoms solely to adjust thyroid dose. Additional information about monitoring. So what about T4 and T3 levels? So checking T4 levels, there's actually no clear data that using T4 levels helps in the treatment of hypothyroidism or the management of hypothyroidism. So TSH is really our goal, and T4 levels may occasionally help, but there's really not any great data that that's the case. So in the vast majority of patients with hypothyroidism, we should be checking TSHs and not checking T4 levels. What about T3 levels? Well, we know that patients treated with levothyroxine and have normalized TSHs often have T3s that are in the lower part of the normal range. There's just not any data to show that this is of clinical significance. And if we treated these individuals with T4 to get that T3 into the mid to upper part of the normal range, we would almost assuredly be suppressing a vast number of these patients. So there are recommendations about specifically not measuring T3 in these patients because it does not help it in the management, and we know that the T3 levels are on the lower end. So why do these dose requirements fluctuate in some people? So in some individuals, you may have them on a dose of levothyroxine and their levels go up and down. And I think an important thing to think about are things like malabsorption. So patients who have gastritis, whether it's atrophic gastritis or Helicobacter, and then importantly, celiac disease. So we often screen patients for celiac disease. It's another autoimmune condition that regularly coexists with hypothyroidism. And so we look for that in patients who have fluctuating dose requirements. We also will remind people that they should be taking their levothyroxine either 60 minutes before breakfast or at bedtime 3 hours or more after their evening meal, and they shouldn't be taking levothyroxine with other medications and supplements. So a little bit about the patients that have continued symptoms despite treatment for their hypothyroidism. These can be a challenging group of patients. So with these patients with continued symptoms, I think you really have to say, what can we do to help these patients? So there's a little bit of additional history that we'll ask for. We need to make sure we're treating these individuals with empathy, and then think about additional diagnostic tests to look for other causes of their symptoms. So I always think it's important to think about the time course. So did their symptoms get any better when they started levothyroxine? So if they were an individual who had a high TSH, got started on levothyroxine, we normalized their TSH and they felt no better, I think that those symptoms are unlikely to be related to their hypothyroidism. I think another important consideration is sleep. Many patients do not have adequate sleep. They may have sleep apnea or other sleep disorders, and I think it's important to ask about those. Asking about other stressors, work, family, medical stressors, and I think giving patients some empathy and listening to their symptoms can be very helpful as well. In those patients who just still don't feel good, despite being on levothyroxine and having a normal TSH, I generally try to make sure that these patients are in the lower part of the normal range, certainly not suppressed. And then I consider other causes. Could they have anemia? Could they have hepatic or renal disease? I think about cortisol excess, so Cushing's syndrome in many of these patients. I think about sleep apnea and often order or send patients for sleep studies or sleep apnea testing. Do they have depression? And could these symptoms be side effects from other medications? Once you've excluded these other conditions and patients don't have any, you've really managed any of these other conditions, and then patients start to ask about treatments other than levothyroxine, well, what should we do? Well, first of all, I start to explain the sort of physiology of hypothyroidism. I really tell them what the TSH is. It's your brain or your pituitary gland's own thermostat for whether you have enough thyroid hormone in the system. Remember, if we're talking about T3 and T4, T3 is the more active hormone of the T3 and T4. It has a rather short half-life, whereas T4 has a very long half-life, about a week. And the vast majority of the thyroid hormone that's made by your thyroid when it's working properly is T4. We also talk about the different medical societies' recommendations, which I'll mention at the end of this presentation. So what about some alternative therapies for hypothyroidism? First, desiccated thyroid. A common one is Armour thyroid. This is derived from domesticated pigs, so it's dried pig thyroid. You often might see it measured in grains, so a grain is 65 milligrams, not micrograms, of tablet content. That includes T3 and T4 in a much higher ratio, 4.2 to 1, than is in the normal human thyroid, which is 17 to 1. So these patients get a lot more T3 than the normal human thyroid would make. And there's also a significant variance in dose, as well as a lot of other things that are not T3 and T4. With regards to desiccated thyroid therapy, there is one crossover study comparing desiccated thyroid with levothyroxine. This study was powered for quality of life endpoints, and it was designed as a superiority trial. It did show a minimal weight loss in the desiccated thyroid group. Unfortunately, or fortunately, it did not show any improvement in quality of life over this 16-week trial. So this was really a negative study. And I'll mention that all of the medical societies that make comments about desiccated thyroid suggest that it not be used. So T3, remember, has a short half-life, so if it is going to be used, it really needs to be dosed about 2 to 3 times a day. There's no available extended release formulation, and the normal ratio of T4 to T3 is about 17 to 1. You shouldn't use T3 therapy alone for the treatment of hypothyroidism. If you're going to use a combination of T4 and T3, there's a question about adverse effects from this therapy. There are a study that looks at 1,000 patients followed for a year and an observational arm that looked at patients for 9 years. They did not show any increase in mortality nor any increase in morbidity such as cardiovascular disease, AFib, or fractures. So if you are going to add T3 therapy to T4, a dosing recommendation is to use, if a patient has a dose of 100 micrograms of levothyroxine prior to adding T3, you should decrease their levothyroxine dose, and the equivalent dose ends up being about 88 micrograms, and giving 5 micrograms of T3 in a divided dose. So this would be a patient who would get 88 micrograms of levothyroxine and 2.5 micrograms of T3 twice daily. Those T3 tablets, the smallest ones available are 5 micrograms, so patients have to break a tablet in half and take a half a tablet twice daily. In terms of monitoring therapy, I tend to get labs 2 to 4 hours after their morning T3, T4 dose. Our goal is to normalize the TSH, make sure that we've maintained a normal T4, and ensure that the T3 is not elevated. So you're really looking for a T3 level that is in the normal range. And these are recommendations from a number of different societies about what to use, and you'll see that DTE, or desiccated thyroid extract, essentially everybody says no, don't use it. If we look at levothyroxine alone, everybody says don't use it alone. And if we look at the combination T3, T4, the American societies, so the American Association of Clinical Endocrinologists, or ACE, and the American Thyroid Association don't support its use. The British Thyroid Association and the European Thyroid Association are a little bit more lenient and say, well, maybe it can be considered. So in conclusion, hypothyroidism is very common. 5% of the population has overt hypothyroidism, 10% has subclinical hypothyroidism. TSH is the best screening test. If you get a T4 and a TSH, you'll diagnose all hypothyroidism. You can start a full replacement dose in young, otherwise healthy people, about 1.6 micrograms per kilogram for leaner individuals. And a goal of therapy is to normalize the TSH, which should relieve symptoms in the vast majority of patients. If dose requirements are high, consider looking for GI factors, screening for celiac disease or atrophic gastritis, and make sure that patients are taking levothyroxine appropriately. Remember to speak and also listen with empathy in patients who have continued symptoms despite treatment of their hypothyroidism. And you can consider T3, T4 therapy in a highly selected population, and often this is undertaken by an endocrinologist. Thank you for your time, and I hope you enjoyed this talk on hypothyroidism.